Dr. Rohit Prakash, he is our, I can say, star from this region, from India. And he is our international judge also for ACRS Film Festival. And he has several of the innovative techniques. But maybe I think 20 years back when I heard your presentation, it was only on, mostly on posterior polar cataract, 25 years back. But from that time onward, I think you have done almost everything, whatever, any surgical cataract procedure.
You're so kind with your words, sir. I think you're winning best of the best. Hello. Hello. Am I audible?
Sound
Yeah, now it's okay. I think your winning best of the best way back was, if you ask me, the real source of inspiration, your double lens one, which took the whole American society by storm. Thank you, sir, for the kind words. So I would be taking up posterior polar cataracts, all the ways to skin the surgical cat. Well, what is known is that preoperative anterior segment OCT is very important because that helps us to diagnose whether there is a pre-existing posterior capsular defect or not. This has been shown by Pujara et al. And flax also has a very important role, which I will talk later on. A small rhexis or an oval rhexis is a very important fact, as Kiranjeet Singh has shown in his oval rhexis technique in posterior polar cataracts. So this is a very small, this is a very soft cataract in which I had not done in a pre-existing cataract. So here what I'm trying to do is I'm trying to have stable chamber settings. Second is I'm trying to do viscoseparation. Mind you, I had not done any hydrodissection or hydrodelineation in this patient who had a pre-existing defect. The fluidics which I'm using are low fluidics of 20. Now what does this low fluidics do? It creates a situation wherein there is no of the fluid into the anterior chamber. The anterior hyaloid face there is no chance of the anterior hyaloid face to be broken. So this you will find at the end of the surgery how things have come out to be. With the low fluidics, what I was able to achieve was that I was able to have the same size of the posterior capsular rent which was there initially, and it ended with a beautiful IOL implantation after IOL capture. So this is another aspect which has to be borne in mind is the hydrodelineation. This is, here you will see that I'm doing hydrodelineation layer by layer, as has been shown by Vasavra et al. So inside out hydrodelineation can also be done, but the only problem is that at times it is difficult. So in hard cataracts, it is not possible to do hydrodelineation. So after doing layer by layer hydrodelineation, what I'm doing is that I'm taking out the inner layer. So the shield of the posterior layer is definitely there in this patient. So that process is continuing. So still the posterior capsule has not been exposed, which is an open posterior capsule. So I'm continuing slowly and diligently. And here at this point of time, I'm creating an escape route, which has been shown by Bob Osher et al., wherein there is not much chance, stable chamber settings again. And now what I'm going to do is I'm going to use the epinucleus as a shield. When I'm going to use epinucleus as a shield, I'm going to create a situation wherein the epinucleus is going to protect the open posterior capsule and avoid a situation in which the anterior hyaloid face can be broken. So this process is continuing. So here you will see that at this point, till at this point, the posterior capsule, open posterior capsule has not been exposed. The only difference which I would have done had I done this again, I would have used an IOP of 20 in this patient. So this is the flax, no doubt, gives an advantage because herein there is no hydro procedure. Femtodelineation is done, and you will find that the low IOP fluidics are being used of 20 in this patient. The offset of 700 microns creates a situation in which the epinucleus is femtodelineated, epinucleus is acting as a shield, stable chamber settings. Now the epinucleus is being taken out. Now once that will be taken out, the intraocular lens can easily be implanted in the sulcus. This was a patient who had an intravitreal injection of injection which caused a posterior capsular tear. So now I come to the stratified phacoemulsification technique to enhance safety in posterior polar cataracts. This technique doesn't involve any hydro procedure. There is no flax. There's an epinuclear cushion which is left behind which protects the posterior capsule. So this was an initial work of Chi Soon Fake which we modified. Herein you will find that after the chopper is placed superficially at the junction of nucleus and in epinucleus for immobilization, the phaco-tip impales, and when it is impaling, the impaling nucleus is pulled, whereas simultaneously the superficially placed chopper immobilizes the nucleus, and what happens is that the nucleus is separated from the outer nucleus. So let's see this small video in which there is a posterior polar cataract in this patient. So you will find that after doing the routine sculpting in this patient, what is going to happen is, I think I've increased the illumination, I've separated into two halves. After separating, I'm going to do cross-chopping as has been taught by Chi Soon Fake. So this cross-chopping is done. After doing the cross-chopping, what I'm going to do is I'm going to separate the nucleus from the epinucleus by immobilization and by the chopper and simple pulling it inside. That creates a situation in which we are able to have an epinuclear shield left behind which protects the posterior capsule. Mark my words, I had not done any hydrodissection or hydrodelineation. Again, cross-chopping, holding it and pulling it forward. So I have left behind an epinucleus shield in this patient. Now I'll go sideways, hold it, and after holding it, I'll pull it to the center, separating the nucleus from the epinucleus. This creates a situation again wherein the posterior capsule is being protected from all sides. The last one which is being done is that I'm going to hold it, pull it, and I've been able to take out the central nucleus in a posterior polar cataract, leaving behind a big epinuclear shield. And you will find that the IOP settings in this patient were 24, which was very anterior hyaloid phase friendly. So, there are certain things else which you can also do. The nuclear manipulations, you can just rotate it. You'll see how it is being rotated by manipulating without causing any problem whatsoever to the posterior capsule. So I would like to acknowledge the works of Robert Osher, Abhay Vasavra, Chi Soon Fake, Lisa Arbiter, and Lalit Singhal in this posterior polar cataracts. Thank you so very much for your kind attention.
Thank you, Dr. Rohit Om Prakash. This was just outstanding. You showed that very slowly, steadily, you took the nucleus out and removed it.
Yeah,
so I think it needs patience and techniques we have to follow.
I think the only thing is that we should not rush into doing these things in a posterior polar cataract. Any patient who has a grade 2 or more, where with the with the phaco tip you can hold the nucleus. That is the time when after separating that part of the nucleus from the other nucleus, when you hold it and you separate it with the chopper, you can practice it. Eventually you can use it in all types of cataracts, but it has a limitation in soft cataracts where you cannot hold it.
So that will prevent the complication, no?
Yeah, absolutely, absolutely. Yeah.
Thank you, Dr. Saab. Thank you, Dr.
Thank you, Rohit.